you everyone for joining us this evening, and welcome to tonight's session on SafeScript New South Wales real-time prescription monitoring, what you need to know. My name is Michael. I'm the Digital Health Officer from Nepean Blue Mountains, PHN, and I'll be your host for this evening, along with my colleague Melissa, who is working behind the scenes to ensure that all will run smoothly. Before we begin the session, I would like to acknowledge the traditional owners of the land in which we all meet today. For myself, I'm in the Cabral clan of the Darug Nation, and I pay my respects to Aboriginal elders, past, present, and emerging. I would also like to extend my respect to all Aboriginal people present here today. Just a few housekeeping tips. The webinar runs for an hour and a half. Participants are on mute for the duration of the webinar, and this session is being recorded. All Q&A will be facilitated through the Zoom Q&A box located on your control panel. There will be roughly about 15 minutes designated time at the end of the session to go through these. We'll be monitoring the Q&A to ask questions and send comments to our panelists. If you see a question that is of interest to you, please feel free to give it a thumbs up. This will move the question up, and therefore it is more likely that we can answer the question during the webinar. We'll do our best to answer your questions live during this presentation and throughout the panel discussion. The chat function has also been disabled for attendees. So I'll now introduce to you our main speaker for this evening, Andrew Hargreaves. Andrew is a program manager for the New South Wales Real-Time Prescription Monitoring Program, SafeScript New South Wales. He's a clinical pharmacist with experience in a wide variety of acute care settings, including critical care and acute pain management. In recent years, Andrew has been working with eHealth New South Wales to enhance safety and quality of the clinical software systems used in New South Wales hospitals. I will now hand you over to Andrew. Thanks, Andrew.
Good evening, Michael. Thank you very much for that introduction, and thanks for the partnership that we've had with the Nepean Blue Mountains PHN in deploying SafeScript New South Wales. Just checking that that's come up on screen now.
Yes, it has, Andrew.
Thank you very much. So thanks very much, Michael. I'd like to also introduce a couple of panel members who are going to work with us tonight, presenting some case studies. So the first is Dr. Hester Wilson. Dr. Wilson is a GP and addiction medicine specialist. She's the chair of the RACGP Special Interest Group in Addiction. And Dr. Datta is an addiction medicine specialist also from the Nepean Blue Mountains region. He's a clinical lecturer at the University of Sydney as well. And lastly, Gabriella Kelly-Davies is our consumer representative for this evening. Gabriella has first-hand experience of the benefits of interdisciplinary pain management, which has helped her in a lifelong struggle with occipital neuralgia and chronic migraine. Her biography of Pain Australia's founder, Dr. Michael Cousins, was published in 2021. So I wanted to thank Gabriella, Son and Hester for joining us this evening to talk about SafeScript New South Wales and what it means for you in the Nepean Blue Mountains area. I too would like to acknowledge the traditional owners of the land in which we meet today and the elders past, present and emerging. And for me, that's the Bidjigal people of the Eora Nation. I acknowledge the ongoing connection that Aboriginal people have to this land and recognise Aboriginal people as the custodians of this land. I'd also like to acknowledge any Aboriginal people that are present here today. So this evening, we're going to cover a few things about SafeScript New South Wales. We're going to cover what it is. We're going to cover a little bit about what medicines are monitored, how you can register and use SafeScript New South Wales, and importantly, how you interact with it in a day-to-day way. I'll also cover some important privacy and legal considerations. We'll run through some of the education and training support that's available for you, as well as some work we've done in partnership with the PHNs to update health pathways, as well as a brand new 24 hours a day, 7 days a week clinical advice line, which you can call if you need help. We've got some case studies, and finally we'll have a Q&A session. So by the end of the session, you'll have a good understanding of the SafeScript New South Wales clinical workflow. You'll know how to use SafeScript New South Wales to analyse and interpret the information to inform best practice patient outcomes. You'll have the ability to use current best practice clinical guidance, including best practice communication skills, to manage the patient's prescribed monitored medicines and their wellbeing. and you'll have the ability to identify and access critical information and resources to support your clinical decision making. So drug-related death and mortality. So drug-related mortality and harm is a serious public health issue in New South Wales and Australia more broadly, and indeed the world. Every year, far too many people are killed and harmed from their use or misuse or unsafe use of monitored medicines. The statistics on the screen are here. What's most important is that really over the last 2 decades, there's been year-on-year increases in mortality associated with these medicines, by and large, with a slight reduction in recent years. Nonetheless, it's a serious public health issue that New South Wales government is committed to tackling. We're also seeing here in New South Wales consistent and increasing harm, particularly in that related to opioids. We see ED presentations that are increasing in relation to opioids. We see consistent and increasing use of naloxone administered by ambulance officers, which indicates the degree of use of opioids in the community, as well as increasing rates of opioid-related deaths, up to 5.4 deaths per 100,000 population in 2018. So that sets the context for why SafeScript New South Wales is important. SafeScript New South Wales is part of New South Wales Government's commitment to reducing the harm caused by monitored medicines, which I've just described for you a moment ago. It's a digital health system that provides prescribers and pharmacists access to a patient's prescription history for high-risk medicines such as opioids and benzodiazepines. It will give you, or it will use information that's collected from the prescription exchange services, incidentally to the activity of pharmacists and prescribers, collect that up, synthesize it into a patient-specific list and present that back to prescribers and pharmacists when they're conducting their duties. And lastly, so I've talked about the use of SafeScript New South Wales by clinicians as a clinical tool to support them in their decision making. Lastly, the pharmaceutical regulator in New South Wales will have access to the information in the system and will progressively use that information to adopt increasingly proactive regulatory activities. Okay, so the medicines that will be monitored in, oh my goodness, there we go. The medicines that we monitor in SafeScript New South Wales are on the screen here. Rather than go through them for you one by one, I'll talk a little bit about why these medicines have been included on the monitored medicines list. So New South Wales Health formed an expert panel comprising academics, clinical pharmacologists, and clinicians to advise us on the medicines to include in the SafeScript New South Wales system. We formed a set of criteria that we used to assess medicines that were considered for inclusion. The criteria were a medicine had to have an evidence of harm in New South Wales or more broadly in Australia. So there needed to be evidence of a pattern of prescribed use, dependence and fatal and non-fatal overdoses. There needed to be a trend in prescribing that showed evidence of increasing prescribing rates as well as non-prescribed use or abuse in an Australian or international context. We considered the substitution effect, so the potential for a medicine to, the potential for one medicine to be monitored and then be immediately substituted for another one. And we considered the regulatory burden. We considered the regulatory burden and the utility of the information for clinical care in the considerations as well. Lastly, we tried where we could to be consistent with the medicines monitored in other jurisdictions, so that prescribers, in particular those in border communities, could have a consistent experience as they deal with multiple systems. So to register and use SafeScript New South Wales is really straightforward. So there's a QR code at the bottom of the screen here. My colleagues are going to place the registration link into the chat as well, and you can register quite quickly. You could probably register whilst you listen to this presentation this evening. It will take you about 5 minutes to do, and all you need is your APRA number, your APRA registration number, and access to your email address and your phone. you will also circulate the registration link after the presentation as well. So that registration process will take you through a couple of steps, and you'll register a password, and that will be your password to access the portal. You'll be provided a link to log into the SafeScript New South Wales portal at that time. Once you're registered, you should take the opportunity to make sure your clinical software is up to date with the latest version and connected to the SafeScript New South Wales system. There's information on how to do that on our website, and when you get these slides circulated to you, the link will be included. All of the major software is integrated with the system to receive notifications and alerts, and I'll talk to you about that in a moment. In terms of data collection, provided your system is connected to the prescription exchange service for the purposes of electronic prescribing or the electronic transfer of prescription scheme that predated e-prescribing, provided your systems are connected to those services, the data will be collected and sent to SafeScript New South Wales automatically. There won't be anything that you need to do. Once you've configured the SafeScript New South Wales system in your desktop software, you don't have to do anything more except log in each day, and then nothing will happen really until you prescribe or dispense a monitored medicine, at which point you'll receive a notification into your desktop software. I'll go through those now. So there are 3 colors of notification that you'll get in your desktop software. It'll appear in the bottom right, and I've got an image of what that looks like in coming slides. That notification will either be green, amber, or red. If it's green, that means either there's no information in the SafeScript New South Wales system for that person, or that all of the information in the SafeScript New South Wales system is from a single prescriber in the same medical practice. Really, that just indicates if you're the prescriber that's you, and you therefore know all the information you need to know about that person's monitored medicines history. You could get an amber notification, which is where there is information in the system, but it relates to more than one doctor. At that point, you can then log into the system and consult the information and see what other prescribers are prescribing for your patient. And lastly, there's a red notification. So in the instance that the prescribing history and dispensing history in SafeScript New South Wales meets the threshold where we've considered that there is a really high risk of harm, then you will receive a notification that indicates there's a high risk situation that you should consult the database for information about. So this is what the notifications look like. It's been slightly enlarged for effect, but in the bottom right-hand corner, primarily of your screen, you'll get an image which shows you a very little bit of information. It'll talk about the person's name, and it'll give you the color of the alert. All you need to do is click on that image, and it'll take you through to the SafeScript New South Wales portal to that patient's profile directly. You may need to log in along the way, depending on whether or not you're logged in at that point. But that's all you need to do. You just need to click and go straight through into the portal. So I mentioned the high-risk situations, and these are the alerts that we have in the SafeScript New South Wales system. There are 3 high-risk situations which we generate alerts for. The first is for concurrent prescribing of potentially harmful medicines in a 30-day period. We chose a 30-day period because it's more likely within a 30-day period that the patient is taking those medicines concurrently, which is obviously where the risk comes from. We selected 4 combinations which we know from the evidence is the highest risk of harm. So that's fentanyl, combinations of fentanyl and other long-acting opioids, combinations of fentanyl and benzodiazepines or Z drugs, and then combinations of methadone and other long-acting opioids, and combinations of methadone and benzodiazepines and Z drugs. That's not to say that there aren't other combinations of medicines monitored within SafeScript New South Wales that aren't unsafe or that aren't safe or are unsafe. Absolutely, there are. What we chose is the absolute highest risks and the ones where we know that they're most likely to cause serious harm. The second group or the second high-risk situation that gets a SafeScript New South Wales alert is where there's more than 4 prescribers involved in the patient's care and actively prescribing monitored medicines within a 90-day period. This is a threshold where we know that people in that situation are at an increased risk of harm. and we provide information about that in the SafeScript New South Wales system. And lastly, the opioid dose threshold. So this is an alert where we can calculate the average opioid dose based on oral morphine equivalents in each in a rolling 90-day average, and then average it down per day. So we get to an average daily dose of oral morphine equivalents. And if that average daily dose is more than 100 milligrams of oral morphine equivalents per day, that generates a SafeScript New South Wales alert. We know that someone who's taking doses of opioid of more than 100 milligrams OMED in one day are at a 5 times risk of mortality compared to the norm, and we know that risk is dose dependent. So there is also an increased risk of harm at 50 milligrams and other thresholds. However, the threshold we've chosen is 100 milligrams based on the advice of the expert panel. Okay, I'll quickly run through a demonstration of the system. So if you are logging in through the notifications through your desktop software, this is kind of what that will look like. So you'll see the warning, you'll go and click on the notification and enter your daily PIN, which you've set up earlier in the day. So you do that, and then it'll take you through into the patient's profile. What you can see in the patient's profile is their demographic information at the top of the screen, their name, date of birth, where they live, and their individual healthcare identifier. And then the bottom part of the screen, you'll see their transaction history. This is divided into prescribing transactions in blue and dispensing transactions in green. That's indicated here on the left, as well as with information here on the right. What you'll see is when the medicine was prescribed, what the medicine was, and it will include their directions in this section here, as well as who the practitioner was that was involved. And in the case of a dispensing transaction, it'll include information about both the pharmacist and where the pharmacy is located, as well as the prescriber and details about the prescriber and when the prescription was written. There's also an indicator here on the left-hand side, which shows if there is an alert that's been generated for that person. Here, this is what we have here is an indication with the alert, and it's got the information that's printed here in the screen as well. That tells you the information about what has caused the alert to fire that day. In the top of the screen, there's also 2 buttons here, so you can see a list of all the alerts that have been generated for the patient over history and when those notifications and alerts were generated, as well as you can see the access history. So what this helps you to do is understand, particularly for a pharmacist, you can see whether the doctor that wrote the prescription that you're dispensing looked at SafeScript when they were writing the prescription or not. For a prescriber, you can see, say you're a GP, you can see what the prescription, or whether or not the specialist that maybe suggested that you write that prescription, whether or not they've checked the SafeScript system before giving you that suggestion. So there's some ways to kind of use the information to help you, I guess, validate what's happening. The other way that you can log into the SafeScript New South Wales system is by through the portal and directly search for patients if you don't get notifications for them. So what you do there is you go to the website, you log in, and then you go through process to enter in the patient details. So you enter in their first name and surname, you enter in their date of birth, and then all you need to do is search for the patient. You'll be presented with a list of people that meet those criteria. You can then filter for those, select the one that you want, select them, and then it will take you back into the patient's profile, which is exactly where we were before. It's important to remember that SafeScript New South Wales doesn't instruct you on what you should or shouldn't do, or whether you should or shouldn't prescribe or dispense medicine. That decision remains entirely with you as the health professional. All SafeScript New South Wales is here to do is to provide you some additional information and additional context to help support you make that decision. You're best placed to make those decisions in consultation with the patient based on their individual needs and their circumstances. And we have a number of clinician support tools and resources available to assist you. So I'm not sure if there'll be people in the audience this evening about the use of SafeScript New South Wales in public hospitals, but if there are, public hospitals and clinics in New South Wales aren't currently integrated with SafeScript New South Wales. That means that prescribers and pharmacists will need to access patient records using that patient search methodology that I just described in the health practitioner portal. It's important to be aware that many of the prescribers and pharmacists registered for the opioid treatment program in New South Wales are either not using integrated software or they're not using systems to record the OTP prescribing and dispensing they do. This is particularly important because that means that information about OTP prescribing and dispensing isn't consistently recorded within SafeScript New South Wales, and so you can't use SafeScript New South Wales to determine whether or not someone is or isn't on OTP or what their current dose is. So please bear that in mind when you're using the platform. Prescribing and dispensing from public hospitals and clinics isn't included in the SafeScript New South Wales system either. But every hospital prescriber and pharmacist is eligible to register for the system and can use the system to support their clinical practice in hospital by using it to consult the system to find out the patient's medication history. Okay, in terms of privacy, security, and legal considerations, I think I wanted to mainly emphasise that we are quite restrictive in terms of who can access the information in SafeScript New South Wales. So we control that with the help of AHPRA. So only prescribers, dentists, and pharmacists are authorised to access the SafeScript system. And part of your registration process is you will use your AHPRA registration number to confirm that you're registered and an appropriate person to be accessing the system. We'll use the email address that you've registered with AHPRA to contact you, to issue you your password, so that we get a confirmation that only people that are registered are actually accessing and using the SafeScript New South Wales database. Then every time you use the system, you'll be prompted to log in, and once a day you'll do a multi-factor authentication check. Kind of like when you use maybe internet banking, you'll get a code sent to your phone, and you just need to enter that in to confirm that you confirm who you are, and then we'll be able to take you through into the SafeScript New South Wales system. There are penalties that apply for unauthorised use, and that's within the Poisons and Therapeutic Goods regulation. People in New South Wales, authorised users of SafeScript New South Wales system are only authorised to use the system in support of treatment of their patients, or to support them to provide advice to other health professionals that are treating those patients. So it's prohibited under law for you to look up the details of people who aren't those that you're providing care to. The consumers are able to request copies of information that's held about them in the SafeScript New South Wales system from New South Wales Health, and there's information on how to do that on our website. So if people are asking you in your practice or in your pharmacy for information about what information is stored in the system, there's information on our website you can direct them to, and we provide them a report. So there's no need for you to feel like you're in a position where you need to do that. And we've got all the information in the system is encrypted using the same level of encryption as the electronic prescribing system. So it's secure, and we do security testing to ensure that's the case. Okay, so the implementation support we have available for you, first and foremost, is education and training sessions. So we've got CPD accredited learning modules available through the NPS Medicine Wise. The information about how to access those is here on the screen and also on our website. So those modules have information about how and when to use SafeScript New South Wales, information about monitor medicines in clinical practice, and information about how to communicate and care for patients using monitor medicines. So there's 3 modules, they're about an hour each, and they're all accredited for CPD points. We also have primary health network facilitated education sessions, such as this one, for prescribers and pharmacists. And we've been partnering with other professional organisations like the RACGP and PSA conducting webinars as well. And lastly, we have help pages available on our website and in the portal to help people use the system. Secondly, we've enhanced health pathways with contemporary information about SafeScript in New South Wales, as well as information about how to use the system in the context of your clinical care. So the Hunter New England and Central Coast Primary Health Network was our key partner, and they developed these core materials that contain the key information about the system and how to use it. And they've made those available and then helped other PHNs tweak those for the local context, adapt that into the health pathways and make that available with some additional information that's there to reflect the local services on offer. The intent of this health pathways platform is to promote GP-led care wherever it's practical to do so, supported by appropriate clinical referral pathways and local specialist services where they're available. There's information here on the screen about how to go ahead and access health pathways in your area, and information there is on the login and password information as well. And again, you'll get these slides provided to you, so you've got that information. So for the SafeScript New South Wales clinical advice line, this is the number for that service that's on the screen here. And then again, there's information about how to access the SafeScript New South Wales clinical advice line on our website. So that number is available on our website as well. This is a dedicated telephone service which you can call 24 hours a day, 7 days a week, to be connected to initially a clinical nurse consultant with expertise in pain, addiction, or mental health, who can provide you direct support when you're responding to the needs of patients who may be at risk of harm, whether that's because of an alert or because of another matter relating to their care from pain, addiction medicine, or mental health. You can call this number and get clinical advice. They are able to help support safe de-escalation of high doses of benzodiazepines and opioids, and then support you in a transition to safe prescribing practices. They've got a lot of information about interdisciplinary management and patient-focused self-management skills, and where that's appropriate, and they're there to guide appropriate management and referral to other clinical services where required. If that clinical nurse consultant isn't able to help you, isn't able to give you the guidance or advice you need, they can direct your call onto a medical specialist in one of those areas as well, and a medical specialist can call you back to give you some information and more support. So this is really in response to concerns we had from stakeholders during our planning that people might find themselves at the edge of their comfort zone in a situation where they're not quite sure what the most appropriate next step for them to take is. They need some advice there in the moment when the patient's with them to decide what they're going to do for that person now, and some assistance in determining what they're going to do next for their patient. And this service is there to help bridge that gap. It's completely free and doesn't require any provision of any patient identifying information. It's a service that's there to help health practitioners to provide more appropriate and safer care. It's not a telehealth service. They won't take over care of the patient. They can't provide you a second opinion on the patient's management. They're there to help you in determining the most appropriate course of care. Okay, I'll take a breath now and ask Dr. Datta and Dr. Wilson to join us, and Gabriella to join us on the webinar to talk about some case studies. So they're going to come onto screen now. There's Gabriella. Hi, Gabriella. Hi, Dr. Datta. And I think maybe Hester's on too, but I just can't see her. There she is, there she is. Excellent, thank you very much. Thanks, Dr. Wilson. Okay. All right, so the first case we're going to talk about tonight is a lady called Janet. I'm sure for the doctors in the room, Janet is a very familiar patient in your practice. She's 44 years old and is the long-time patient of a retired colleague from your practice. Dr. Smythe has been prescribing Janet OxyContin for years, and you're now seeing Janet. You see in your notes that she's been prescribed OxyContin 40 milligrams twice a day for the last 6 months, initially commenced at a much lower dose after extensive superficial burns a number of years ago. She's been attending the same doctor and the same pharmacy regularly for her prescriptions. She's on no other prescribed medicines. She's got no prior history of postnatal depression. She's a non-drinker, non-smoker, and no other significant health issues. But you receive a notification when you go to prescribe for her that Janet is on a high dose, a high OME dose of OxyContin, because she's taking that for 80 milligrams a day, which breaches that 100 milligram oral morphine equivalence threshold we spoke about earlier. So I guess, firstly, as a GP, Dr. Wilson, what would you be your first thought at this point in Janet's consultation?
Yeah, so I think the first thing for me is this can be a tricky situation because this is an inherited patient. It may be someone that I don't know very well, that I don't have a strong therapeutic alliance with. And they've come to me, saying, look, I've just got to get my usual scripts. And I'm going, ooh, what's going on here? And so it is a tricky situation. And there can be a little bit of a thought in your head going, oh, look, she's been on it for years and she's not had any problems. Why would I rock the boat and just continue prescribing? And look, and it may well be that this is appropriate. However, I would be saying that we do need to actually do an assessment. We do need to think through what is going on here. And the big flag for me that makes me go, oh, we've got to really think about this, is that she was started some time ago for abdominal burns, 3 years ago. They're gone. And so what are we actually treating? So she started on a lower dose and slowly her dose has ramped up. And so I'm thinking, what are we actually treating? We do need to rethink this. We do need to look at what is actually going on. And it's the start of a conversation. And it may be possible that she'll say, oh, now that you've explained that all to me, yep, let's do something. Or it may be that it's a conversation that takes some time. And I, as the prescriber, have got to be really happy that my prescribing, as I work with her to change this over time, is safe, is not going to lead to harm. As you said, Andrew, people do die, of overdoses. People taking oral medications, doing as they believe they're told by their doctor, they still can overdose and die of multi-drug toxicities. And so I do need to look at, is this appropriate? How am I going to engage? Being there for the long haul and understanding that change can be difficult, but really looking at how do we work together to achieve better outcomes. And for me, I'm thinking taper and terminate this medication with this history.
Thanks very much, Dr. Wilson. So from a pharmacy perspective, and we don't have a pharmacist from Nepean Blue Mountains on the line this evening with us. So from a pharmacy perspective, if I put myself in the community pharmacy shoes, I'd be thinking when I got the red alert, because I'll get it too. So I'm going to want to be looking at, what is Janet's prescribing history? Does it match with what she's telling me is her prescribing history? I'm going to want to see whether or not she's accessing prescriptions from multiple doctors. I'm going to want to be looking at the frequency with which she's accessing prescriptions and try and determine if the amount of medicine she's accessing is consistent and appropriate given the dosage, to make sure that there's no accumulation of opioid in the home. And that's all fine. And for Janet, I'm going to see that she's only seeing one pharmacy. She's only seeing now Dr. Wilson. She's only on the 40 milligrams twice a day, and her collections are consistent. So I'm satisfied from that perspective. So now I'm going to want to speak to Janet about the risk of harm. I'm going to want to engage her in a discussion about things that she can do to minimise harm. I might consider take-home naloxone for her and talk to her about whether or not she and other people in her family know the signs and symptoms of the early signs and symptoms of opioid overdose, and really take that as an opportunity to give some supportive care and supportive information about that, about the risks of harm. And lastly, I'm going to want to speak to her about non-pharmacological strategies to manage pain, and really try and be supporting that mindset around taper and terminate that Dr. Wilson was talking about.
Yeah, Andrew, just want to say as a GP, talking to the pharmacists that are with us tonight, that's wonderful if I've got a pharmacist that can flag that with me and say, have you thought about naloxone? Have you thought about prescribing? And thought about the risk of overdose. So really encourage you guys who are working as pharmacists, do make that phone call, and work collaboratively, because you guys are so important in terms of helping someone change their medications over time. And really encourage you to have those conversations with the GPs that you work with.
Thanks very much, Hester. So Dr. Datta, from an addiction medicine specialist perspective, if a GP is in this situation and calls you for advice, what are your thoughts in this circumstance for Janet?
Yes, I mean, as Dr. Wilson mentioned, it's tricky, especially if you inherited the patient and you just come across that, the red alert of over 100 milligrams of OMED. It's 120 in this case. I think we do get referrals from GPs, often for a second opinion, or sometimes to reassure them that not everyone who is having long-term OxyContin is actually abusing them. And what I tend to do is go through the checklist of DSM-5 and see if we can actually match those criteria with this patient. And if Janet has been on this medication for a longer period of time and is sticking to one GP, one prescriber, and on one pharmacist, and now SafeScript will give us that information as well quite easily, I wouldn't be too worried, and probably Janet is not for me. However, at the same time, I would also look at any objective evidence of the need for the continuation of OxyContin as well, especially at the dose. And as you mentioned, and Dr. Wilson mentioned, I think there'll be a start of a journey where we try and work with Janet and first of all acknowledge that maybe this is not something she needs. And like any other chronic diseases, we optimize antihypertensives or diabetes medications. It's no different to that. And then we work with Janet and start a slow reduction if Janet is agreeing to that. And most of the times we find that Janets are usually happy with that, and maybe they never had that conversation with their previous GPs or pharmacists, and they never realized that there's a need for change as well.
Great, thank you very much. So Gabriella, if I can ask you, we've heard from a GP, an addiction medicine specialist, and a pharmacist, all talking about what they think is best for Janet. But probably Janet's heard in this conversation is you want to take away my OxyContin. So can you give us a perspective from your side of this conversation? How does Janet feel at this point?
Yeah, well, I think that the fact that she's having a different doctor would make her very anxious. Because she's confident in her old doctor giving her the OxyContin. So I think that when she goes in for the consultation, she'd be feeling very nervous and on edge, and possibly very anxious. And so it's very important to be aware of those feelings, and rather than jumping in and saying, oh gosh, why are you on this 3 years later? What's going on? I think the doctor and the pharmacist need to go in very gently and just introduce her to the concept that, long-term OxyContin at that dose, isn't, optimal. And that maybe there are other options for managing her pain. And actually, it would be really good to understand what her pain is. What's the OxyContin treating? But in asking all those questions, that's just going to make all her alarm bells ring, particularly if she really depends on the OxyContin, and also if she's getting a bit of a high from it. So we don't know that, whether it's giving her some sort of benefit apart from the pain relief. So anyway, I think the pharmacist and the doctor just need to go gently and gradually introduce her to the concept that maybe there's an alternative pathway. And if she was in the pharmacy, I think pharmacists really need to be aware that people are very embarrassed, and you know, if they have a conversation with the patient when there's other people there, that could be very intimidating and mortifying. And just to be able to take it offline somewhere potentially, or, you know, another time when there's not so many patients, you know, lining up for prescriptions.
Thanks very much, Gabriella. It's definitely food for thought. Thank you. So we're going to move on now. We're going to speak about Murray. So Murray's a 49-year-old man. He's new to your surgery. He walks in late in the afternoon on a Friday afternoon. He doesn't want to take up too much of your time. He just needs a repeat script because he's in the area, and that's for OxyContin 60 milligrams. So at this point, you check SafeScript New South Wales and see the following in Murray's history. You see he's also on a fentanyl 25 microgram patch. You see he's on diazepam. You see he's on oxazepam. You see he's on pregabalin, and he's asking for now today OxyContin. When you go to prescribe, you see in the system, sorry, that he's got these following alerts. He's got alerts relating to his concurrent use of high-risk medicines. So you see that that's related to his fentanyl and benzodiazepine use. And you see an alert in there showing that he's been accessing these prescriptions from many prescribers at multiple practices over the last 90 days. So sort of flagging some concerns for you here. So this time I might go to Dr. Datta. Dr. Datta, what do you think as a prescriber in this circumstance? What's your first thought, and how where do you start this conversation?
Again, I mean, often we find these conversations to be challenging for us, but at the same time, this might be a wonderful opportunity for the patient to have that first conversation with someone, that there is help out there. And it looks like from the SafeScript information that he's having some issues with polysubstances, and quite a few of them are sedatives, which then brings in a lot of other issues as well. In terms of approaching Murray, I would probably go through an assessment and find out how much it is affecting Murray's life, and how much it's affecting his social life, how much it's affecting his other activities of daily life. Is it something which is ruling Murray now? And is he again ticking those boxes in DSM-5? Is he having withdrawal? Has he got a tolerance now? Is he using more and more of these? Is he sourcing some of it illicitly as well? And I think those things will be part of the assessment. And just to mention to the audience as well, we do have a 24/7 intake line, which is for drug and alcohol, dedicated to drug and alcohol, not the mental health. We do have a drug and alcohol intake line as well. And we also do have a GP helpline Monday to Friday, 8 till 5 as well. So again, Murray can contact us through the intake services. We can do a full assessment. We do have outpatient appointments as well, so we can go through what options Murray may have. We tend to do a physical assessment as well and go through some withdrawal questionnaires, some risk assessments, and of course, educate him about overdose risks. And we do give out orphan or take-home naloxone from our service, and that's something I would offer Murray. And then go through other options as well, what he can have if he doesn't know about inpatient admission. We do have a 15-bedded ward in the hospital, where you can come in and try and come off some of the medications, not all of it. And then we can also explore the option of the OTP, or the opioid treatment program, which again, we offer in Nepean, Katoomba, and in Lithgow.
Thanks, Dr. Datta. So Dr. Wilson, I might go to you now. What kind of information does SafeScript New South Wales give us about Murray, and does it always tell the whole story? Would we change our approach if this person was undergoing palliative care, or would that explain this away, and how would that change your approach for Murray?
Yes, of course. And look, I think when I look at this is a new man that's come into the surgery. He's not that old. He's only 49. Look, doc, I just need a script. And the thing that SafeScript does is it allows you to actually look at what is this gentleman actually taking. And it would be very easy with this just to go, oh, throw up your hands and go, oh no, this person's drug seeking, I'm not going to get involved in this. But you do need to understand what is going on in that person's life. And you're absolutely right, Andrew, that, you know, if this is someone who's, you know, in palliative care, and this is for the end of life care, it is a different story. The other thing is that they may well be taking all these, but when you look on SafeScript, you see that they've actually run out and they haven't actually been able to obtain any more. And so you might think about prescribing a small amount with daily stage supply, because if they are on these doses of opioids and they've run out, they are going to withdraw, and that is incredibly uncomfortable. It really is the most dreadful thing for people to go through. And one of the things that can happen with this is people then go to illicit sources or then start to inject, and he may well be an injector, and that is something that we can think about, but it's really thinking about what is the appropriate thing for this gentleman. And I look at him and I think, if there isn't a palliative care history, and it may be difficult on a Friday afternoon to understand that, he may say that, and then you've got to seek more corroborative evidence, which you may not be able to find at that stage on a Friday afternoon, but he looks to me like someone who would be much better managed by Prasun and his team. And so I would be wanting to support him as a patient to actually access that care, because his use is risky and there is a risk of harm here. And we do know that he's obtaining scripts. We don't know if he's taking it all. We don't know, as Prasun said, whether he's getting additional illicit medicines or other illicit drugs, or whether he's actually selling some of these on. So it doesn't give us all the information. So it is really around being really clear. I am concerned about the risk of harm. I do want to assist you, and I can only do what I think is safe.
Thanks, Hester. And Gabriella, so from your perspective, what do you think Murray's feeling at the moment, partway through this conversation? It's probably going in the direction that the doctors decided not to prescribe the OxyContin for him. What do you think Murray needs to hear from the doctor in that context?
Well, I'd say his alarm bells are going off. I actually hadn't thought of palliative care, but I thought he sounded a bit brusque the way he walked in and said, "Oh, doc, I just want my script." So very confident, but also that might have been just a cover for his nervousness about, you know, getting his medication. So I think he would, I mean, he's on an enormous amount of medication. And so I would think that for whatever reason he's taking it, if someone suggested to him that maybe we should reconsider what he's taking, there'd be lots of red flags and he'd be very anxious and he'd be really, you know, the alarm bells will be going off. So I think, again, it's very important to understand the situation and to take it carefully, because you don't know the background and you need to be sensitive to whatever the situation is.
Yeah. Thanks very much, Gabriella. So I think the two common threads between Janet and Murray, and you'll note this in what we've been talking about tonight, is obviously these are complex situations that don't have easy solutions, and we're not talking to you about the best optimal long-term care for Janet and Murray. We're really focusing in on the conversation on what's the first thing, because obviously taking the first step and peeling the first layer off the onion is you know, crucial, particularly at, you know, in this early stage. So we're really trying to focus in on harm minimization and helpful interventions like we've been talking about. So we want to start the conversation around risks of harm. We want to talk about best outcomes, and we want to talk about setting boundaries around their medicine use. We want to seek advice if we need it. So you can seek advice from a second opinion from another colleague. You can look at health pathways for information. Dr. Datta mentioned some GP support services that are available in the region, as well as the SafeScript New South Wales clinical advice line. All of these are options that you can consider. We want to manage and reduce risks to improve outcomes. So we want to provide information to the patient about about the risks of harm and about what the options there are. We want to enter into long-term collaborative commitments between GPs, the consumer, and the pharmacist, and other services that exist. We really want to narrow down to a single prescriber, a single pharmacy with frequent reviews, and we want to be checking SafeScript New South Wales routinely. Some of the interventions around staged supply, supervised dosing, take-home naloxone, and others are all important harm minimisation strategies as well. And we want to set goals around their treatment. We want to have a tapering plan. We want to consider opioid agonist therapy and other, and importantly, self-management options that exist. And we want to look at what other options there are to surround this person with support, thinking about family, friends, community, other care arrangements, non-medical prescribing, other allied health services. And we want to refer them for specialist services, specialist opinion, and collaborative management where it's appropriate. I'm really emphasising some of the great opportunities and options that exist out there in the allied health space, physiotherapy and psychology as well. So we'll close off the cases with Abdul. Abdul's coming in to seek his prescription for his Targan. He's well known to you. He's been prescribed Targan twice a day for severe osteoarthritis in his hips and knees. He's got a history of recurrent low back pain and insomnia, chronic insomnia. So when you access SafeScript New South Wales, you see this in Abdul's history. So he's been seeing you for his Targan, but you see prescriptions for endone, pandine fort, diazepam, pregabalin, and his Targan, and an alert around his multiple prescriber use and the fact that he's seeing lots of pharmacies to have these prescriptions filled. His oral morphine equivalence isn't that high, 80 milligrams. It doesn't, not that it's not that high. It doesn't reach that threshold of 100 milligrams, but it's still significant. But the key point here is that he's just been seeing you for his Targan, and he's been seeing a whole range of other prescribers to access other medicines. So, Dr. Wilson, I might start with you on this one. So, as Abdul's GP, long-term GP, how are you feeling in this moment?
I think the first thing for me would be, you're seeing other doctors, you're seeing a number of different pharmacies, and you're on these medications. And the first thing for me is that fragmentation of care. And so, look, there may be very good reasons. Abdul may travel for work. He may have family responsibilities in other areas. So there may be really good reasons why he's seeing, different pharmacies and different doctors. And people are allowed to do that. But for me, it's around who is actually managing his overall care, who has a sense of what he needs. He has chronic pain, and yet he's using endone, which is a fast release opioid, which is not indicated for the treatment of chronic pain. He's also using Panadine Fort. Codeine has to be one of my least favorite of the opioids, causes lots of constipation. And once again, it's not something that you would consider for long-term management of chronic pain. Diazepam, he's taking around about 7.5 milligrams on average a day, but how is he using that for his sleep? Is that working? The pregabalin, once again, for me, it's about just ensuring that the combination that he's got is actually helping him and he's achieving the best possible outcomes. And I would be wanting to work collaboratively with the other people involved in his care. It could be that the other prescribers are his specialists. It could, we don't know the details. So it's really looking at how can we improve this. I'm not hugely worried. It's not bad, action stations, but it is, I really want to understand how we can assist you to best manage your medical conditions. And to do that, I need to have communications with the others involved in your care.
That's great, thanks, Hester. So from a pharmacy perspective, I think the most important thing from my perspective in seeing this information is wanting to have a conversation with Dr. Wilson about the prescription that she's written. If that's what's come to me, I'm going to want to consult SafeScript to see if Dr. Wilson's looked at the SafeScript system and seen the information, or prescribed this in the absence of that, and that'll change how I approach that conversation. But I'm really wanting to understand who who is, you know, as Dr. Wilson said, taking responsibility for Abdul's overall management, and how can I support that in the pharmacy where I am. And then Dr. Datta, from your perspective, is Abdul, what do you think about Abdul's risk and Dr. Wilson's approach?
I think the impression I'm getting is that Abdul may be a person who has got very poor health literacy, and he may not understand the interactions between all these medications, and that effectively, actually, they might cause harm to him. He has got an objective source of pain from severe osteoarthritis, and that is real. We know that. And then if Abdul is working, he would need pain relief to carry on with his day-to-day activities. And it may be a matter of just sitting down with him, you know, making him understand that you may not need all these medications, and all these medications actually may cause harm to you, and try to optimize. And I'd probably use Andrew, one of your colleagues, to do a medication review who can, you know, give a lot of time to Abdul and go through each and every medication and go through the side effects as well. Again, I wanted to mention in the earlier case as well, it's not only pharmacotherapy or optimizing the medications, so they would also need a lot of psychological help as well. And again, part of DNA services in the whole of Nepean Patch, we do offer counseling and psychology services in Nepean, Katoomba, and Lithgow, and Hawkesbury as well.
Thank you. Thanks, Dr. Datta. And Gabriella, from your perspective, do you think this would be common? Is this something that from your background in advocacy, you've spoken with other people who find themselves in a position where they see particular prescribers for particular medicines? Is that something that you?
Yes.
Plausible?
Yes, it is. But I would question why he needs so much medication for arthritis in the knees and hips, and wonder why he hasn't been referred to, you know, a pain clinic where he could be self-managing and doing exercise. So it seems like an extraordinary amount of medication for osteoarthritis of the knees and hips, which is so common to people, you know, 60-year-old people. So, you know, again, I really question the amount of medication he's taking, and whether other options have been sort of introduced to him, and how he would react. You know, he says, "Hi, doc, I just need my Tarjan." You know, I wonder, in saying that, it sounds very casual and confident, but I wonder how confident he is. And whether he's wondering whether, you know, he's going to be allowed to take all these medications, or whether someone's going to put a stop to it. But the most important thing to me is ensuring that he's got a multidisciplinary approach, and that he's doing self-management and exercises and weight management and all the different things that you can do for, you know, arthritis of the knees and hips. So with all these patients, I think the common factor is they would be nervous when they go in to ask for their repeats. And I think that their prescribers should be really thinking about the long term and how sustainable this medication regimen is, and whether there are other options for helping them and that would be better for them, you know, like self-management and exercise, and, you know, the variety of things that are available to them.
Andrew, just another thought from me, and I think once again it's around that assessment and recognising that the medications that come off in SafeScript are only specific ones. So he might be on sedating antidepressants or sedating antihistamines. He might be drinking a lot of alcohol. You know, so we've got to look at the other things that are happening in his life in terms of substances or medicines that are sedating, but also looking at his risk. What's his cardiac capacity like? What's his respiratory capacity? Does he have sleep apnea? Those other things that even with that oral morphine, it's 80 milligrams, it's up there, but it's not super high. But he as an individual, as a 60-year-old, what is his actual risk from all the different aspects in his life of actually coming to harm, of having an overdose and dying of multi-drug toxicity? I think it's really important to consider this in patients, to look at them overall, to look at their health status overall as well.
Yeah.
really important, Hester. And from our perspective in the program, we're certainly very clear that SafeScript New South Wales has a whole bunch of information that that has never before been accessible to prescribers and pharmacists, but it is only limited. It's limited by the information that's included. It doesn't have information about Abdul's other medication history. It doesn't have information about his background. It doesn't have information about the services he's been referred to. So all of that needs to come out in the clinical history that you're taking, and this is a tool that just supports and helps you to hone in on that from a very particular narrow lens. So it's really important to surround it with all those other questioning techniques and other thoughts that you've just outlined. Thanks very much, Dr. Wilson. So, all right. So from a wrap-up perspective from the cases, so always be thinking that there may be a lack of awareness on the effects of the medicine and pain management, the dangers of dependence. There may be awareness of that situation, but the person may feel trapped in that context, and there may be existing substance use disorders that surround the situation. Remember that substance use disorder is a medical condition, and drug-seeking behaviours are a symptom of that, and there's plenty of information out there that's available for you to look through about that. Really the importance of helping the patient to recognise the issue, to work with the patient to set goals for their recovery and help them to seek appropriate treatment. We've said it a lot tonight, but the use of non-pharmacological therapy and evidence-based pharmacological options for substance use disorders is obviously important, and always consider the use of other lower risk medicines that might be appropriate. Dr. Wilson, would you mind just talking through a little bit about motivational interviewing in this context? I know it's a particular area of interest for you.
Yes, thank you, Andrew. So look, motivational interviewing techniques and a motivational interviewing approach to conversations with patients is incredibly useful. And I suspect that many of you are doing this anyway. You just maybe don't know that that's what it's called. But there's really good training out there to help you do this. But it basically, at its core, it's about having a conversation that invites the person to build their own case for change, to look through conversation, to help them to crystallize that and to think about the things that aren't going so well. It's not pushing and telling them they must do things. It's about helping them to understand. So lots of education around their medication use and what that means in their life, helping them to understand how it may affect their lives adversely, and helping them to move towards change and leading that, building their own sense of being able to manage this for themselves. I cannot talk about it. It's not a simple thing to talk about and to summarize. But one of the things I would say for me is I started learning motivational interviewing back in the mid-90s, and it's core to every conversation that I have with patients. It's not just about these medications. It's not just about drug and alcohol or smoking. It's about exercise and nutrition and managing stress and medication adherence more generally. It's a really very, very useful approach, and I would really encourage you to seek out opportunities to learn, to read about it, and to look at how you're already using it and how you can actually build this into your practice. In terms of rule and ors, they're nice little mnemonics that you can use. And really, when you're wanting to understand somebody's experience, asking them questions that allow them to expand on their experience, affirming that you're listening and that you want to hear, and that you're reflecting back, and that you're telling them you're trying to understand, or you understand where they're coming from, and you're summarizing what you've heard, is an incredible techniques to assist in terms of really understanding what's happening for that person. And Gabriella was talking before, we know that people, when they're faced with this, will be incredibly anxious and worried and feel like they're not being heard. So allowing this opportunity for people to really express to you what's going on and feeding that back is really, really important and really beneficial. It doesn't mean that you condone or allow or prescribe medications at risky, harmful levels. You know, so you do have to walk a line which says, I hear what you want, I hear what you're saying. At the same time, I need to do what is safe. So it's doing that within those boundaries. So it is around respect, curiosity, understanding, but with boundaries.
Thanks, Dr. Wilson. So that brings us to the end of our presentation this evening. The references that we've used are here and are accessible to you, and the slides once you get them afterwards. So we're going to move into the question and answer section of our presentation for this evening. So I'm just going to look for the chat information. Okay. All right, so the first question we're going to go with is for you, Hester. So there's a question from the audience. I have a few patients who are getting red notifications, but they're compliant and risk aware, but are lower doses compared to when they're coming from the specialist. So what are some considerations in that context for you, do you think?
Yeah, so you're absolutely right, Arshad, that you know, this is something that we see, and it has been quite a source of frustration for many of us in general practice, where we're working with people to cut down their doses for perhaps of their opioids, and then they go to the pain clinic and come back with higher doses. I have seen over recent years that is actually shifting in with the pain clinics that I work with, but I acknowledge that that may not always be the case with some pain specialists. Some pain specialists are very opioid kind of, you know, very happy with higher doses. The reality is that those higher doses are risky. Yes, people can be compliant. They can be doing exactly as they've been instructed, but that doesn't mean, if they're on high doses, it doesn't mean that they're not at risk. For you as the prescriber, it is around you who know your patients. You are well placed to make these decisions. But do be aware that you do need to reassess, and you do need to be aware of what else is happening in that person's life. For example, if they're drinking a lot of alcohol, or if they're on other sedating medications, or if they have other health issues that increase their risk, that you, every time you write that script, are making that decision as their prescriber. One of the things that I would really suggest, and I find it really helpful in my practice, is to take advantage of the 12-month review. And so getting someone else from your practice, or getting the pain specialist, or getting an addiction specialist, depending on what your concerns are, and organising that with the patient. It's so useful to have someone else to see the patient with fresh eyes. I find it, you know, one of the things that can happen for us is, yes, we have that ongoing relationship, but sometimes it's really good to have someone that can see it with fresh eyes, another person in your practice, or another GP in another practice, to just go through and make that part of your yearly review with your patients, to get that second opinion around, is this actually the best option for this person? You know, it's great that you've got them down onto lower doses. Is this the optimal dose, or is there more that needs to be done? The bottom line is that there's really good evidence that people, as they cut down on their dose of opioid and move towards stopping it, and actually stop, generally their pain improves. It doesn't get worse. So, you know, it's fantastic that you've got this long-term relationship. No way is the red notification telling you must not do what you're doing. It's part of that ongoing relationship, working with patients over time, repeated ongoing assessments and reviews towards the best possible outcomes.
Thanks, Hester. Ashad's also got another question here around prescribing of stimulants, and are they going to be monitored? Are they going to be monitored? So yes, stimulants are monitored in SafeScript New South Wales, Arshad. So yeah, psychostimulants are the Schedule 8 medicines, and so certainly alerts around high levels of prescribing, multiple prescriber episodes will be sent to psychiatrists and paediatricians prescribing stimulants if those thresholds are met. And there's also a question from Sabine around nurses working in pain clinics accessing SafeScript New South Wales. So at this time, SafeScript New South Wales is only accessible to prescribers and pharmacists and dentists who are prescribers of Schedule 8 and Schedule 4 medicines. So nurses at this time aren't able to access the information in SafeScript unless they're a nurse practitioner. So only prescribers and pharmacists in those clinics will be able to access the system. Anne has asked a question around the use of SafeScript for patients who don't have a health identifier number, such as private health patients or private health insurance patients who aren't Medicare eligible. So Anne, their transactions will still be collected into the system. However, because they don't have an individual healthcare identifier, it is likely that we won't be able to organise those transactions into a consistent history for that person, like we would if they were Medicare eligible and had an IHI. So in those instances, the transactions will be in the database, and sometimes they'll match with others, but not consistently and not as uniformly. So this probably isn't as good a tool to use in that context as it would be as if that person was Medicare eligible and had an individual healthcare identifier. And then the next question is in relation to the prescription shopping information service and whether or not that's still applicable. So I think the important piece of information here is that SafeScript New South Wales includes records for both private and PBS prescriptions, where the prescription shopping information service is only PBS records, and where the prescription shopping service required you to call them and get the information over the phone, SafeScript New South Wales provides you the ability to look at that information in real time whilst you're prescribing. So you've got all the records that the prescription shopping information service had available to them, but available in your desktop computer at your fingertips during the consultation. So it's probably more easy to use in that context. So whilst that service is still available, I think you'll find SafeScript New South Wales provides you all that information and more. Sorry, this is a long question, so I'll just read it. Okay, so this question's from Arshad as well. Patients are already having discussions about dose reduction, but they're resistant due to previous bad experiences. Sometimes you have to be open and upfront about the danger. Dr. Datta, from your perspective, what do you think here? So this is about someone who's tried a number of times to wean and not been successful. That's obviously going to leave some questions in their mind. How do you approach that situation?
Again, it's difficult, and that's one of the criteria for DSM-5. If someone has tried to go down and has not managed to come off it, and especially there's no clinical need for that medication as well. And I, as a GP, I probably would think about passing the patient to a special service, if not anything, for a second opinion. And I think both Arshad and the patient and the specialist probably will feel more comfortable approaching the patient jointly rather than just suffering in silo and having that uncomfortable feeling when you see the patient's name on your list, that you have to go through that motion again and again still feel unsure about if you're doing the right thing. So yes, that's probably what I would suggest. And again, as Dr. Wilson mentioned, that's another review from another fresh pair of eyes as well. And sometimes when you have seen a patient for a long period of time and probably you treat their children and their parents as well, you may feel a bit uncomfortable posing some challenging questions to them. But for me, it might be easier to pose those challenging questions because I take it from a very objective lens, and that might again help Arshad and in turn the patient as well to at least try and think what can be done. And it happens in our OTP clinics as well. So it's not that all the patients who are on the OTP are not using any other opioids. And sometimes we have to accept that that's going to happen. And as long as we can minimize the harm as best as we can in the patient, I think we have done a job in a way. We cannot expect that each and every of those patients will be able to abstain from using say heroin in my cohort of patients, or in Asha's case, try to go down and stop Dargin altogether.
Thanks, Dr. Datta. Catherine has a question around technical support for the integration with practice software. So is it who do we contact? Do we contact practice software provider, the PHN, or New South Wales Health or SafeScript to get the IT support? So there is information on our website around the common steps to take for most practice software. So you can get that information on our website, Catherine. However, if you need more detailed support, you should contact your practice software provider directly, and they'll be able to give you the support and troubleshooting for that. There is also a support line with Fred, who provide the platform that we use for the SafeScript New South Wales system. However, in most cases, they will, if you call them about integration, they'll direct you back to your practice software provider. All right. Are there any other questions from the audience?
Andrew, there's one here about legal requirements to prescribe opioids, if you'd like me to speak to that.
Yeah, that'd be fantastic.
Yeah, so that was a question in the chat. What are the legal requirements to prescribe opioids for chronic pain or a patient with dependence ongoing? What constitutes a 12-month review? Okay, so first of all, in terms of chronic pain, you can look at what is in the PBS and the TGA guidelines around this. And first of all, it's for extenuating circumstances. It's when nothing else works. And once again, we've talked about the non-pharmacological options, the non-opioid options. Really, what we know works for people with chronic pain is their active management of that, and including non-pharmacological options and talking therapies, counselling, getting support. And opioids are a small amount, extenuating circumstances. The other thing is that it is for sustained release rather than immediate release, and start off with your low potency opioids. So Viceptone, methadone, fentanyl, really they are third, fourth line. And you really need to be thinking hard about using those, or hydromorphone as well, those high risk, higher potency opioids for people in chronic pain, and they should not be used in someone who is treatment naive. In terms of the 12-month review, it is a review with another practitioner. So that can be a GP, it can be a pain specialist, it can be an addiction specialist. So I will always flag this as part of the treatment plan, that I will see you frequently. We will be managing this together. We're in this for the long haul. I want to look at the other non-opioid and non-pharmacological options to support you to have the best possible life you can. But part of this is also a regular review with another doctor. And if I'm really looking I want that GP approach, I want that generalist approach to make sure I'm on track, I'd go for a GP in my practice generally. But if you're in a solo practice, it can be with another practitioner. If I'm concerned that their chronic pain really just isn't being managed and they need that multidisciplinary chronic pain clinic input, and you do have those in your area, if you're in the PM Blue Mountains PHN, then I go for the pain clinic. And if I'm worried about opioid use disorder, as Dr. Datta's been telling us, those DSM-5 things that suggest that this has actually become a disorder of its own, I would be going for the addiction clinic and addiction specialist review. So what I'm wanting from them is this addiction? Should we be thinking about opioid agonist treatment, methadone, buprenorphine, or the long-acting injectables to help manage this person's condition? They've now developed an opioid use disorder. So really setting that up as core to what you do. In terms of the other legal requirements, if somebody has an opioid use disorder, you need to have an authority to prescribe, and this is through New South Wales legislation. You need to fill those forms in, in order to continue prescribing. It's really important to be aware of that. If they don't have an opioid use disorder, if they don't have a drug dependency, then you don't need to fill in that schedule. But I would really be flagging with you, make sure that you are doing legal scripts with figures and words, and that you're really keeping an eye. If I think they're on a dose of 60 milligrams a day, that's actually what you're prescribing. Quite often I will see when I look at SafeScript that the doctor, I'm prescribing 60 milligrams, but the person's starting to come in early. And they're actually, when you look at their average daily dose, it's much higher. So really do keep a bit of an eye on that. So that's my riff on legalities.
Thanks very much.
I can add a couple of points, Andrew.
Yeah, of course you can, yeah.
So first of all, patients who are on OTP, so methadone or buprenorphine, if I can say that they're not very good analgesics for acute pain. So often they would need an opioid, but not many instances outside the hospital setting though. So in the community, if a patient is on OTP, then you would need, along with the form which Dr. Wilson mentioned, a supporting letter from the prescriber, which needs to be attached with the form when you apply to the pharmaceutical regulatory unit, which will then give you the authority to prescribe another opioid for the pain. And that is usually for up to 90 days. And for non-cancer patients, you can only prescribe under 100 milligrams OMED. If it's more than that, then you need a specialist to be involved in that patient care. Another point is that currently we do not have access on the SafeScript if the patient is on the OTP as well. So that's something we need to be mindful about as well when you're doing the assessment. In terms of prescribing OAT, especially in the remote and rural areas where there are not many of us as prescribers, GPs can initiate buprenorphine and can prescribe up to 20 patients without going to further training, which is OTAC in our New South Wales. You cannot initiate methadone, but you can prescribe methadone once it has been initiated by an addiction medicine specialist.
Thanks, Dr. Datta. Okay, so I think we've come to pretty much the end of our evening now. What we might do is just run around the panel quickly, just for one final parting thought for the audience as they go and leave the webinar and get ready for the use of SafeScript New South Wales in their practice. So Dr. Datta, you're on a roll. I might start with you.
Just wanted to say that help is out there, and for GPs and for patients as well. So if you need any help, just pick up the phone and we're there to help you and advise you.
Thanks, Dr. Datta. Dr. Wilson?
Thank you. So look, thank you everybody for your attention tonight. Look, for me, SafeScript is a tool. It's really useful. And one of the things that I find is that people will tell me this is what their medications are. And I check on SafeScript and they're exactly right. That is what their medications are. So it can be really useful as just a corroborative kind of information that helps you to understand and trust your patients that what they're telling you is actually legitimate and real. The other thing is, yes, we are responsible for our prescribing, and we do need to prescribe responsibly, but we are also the ones that know our patients best. And doing good assessments and understanding the individual circumstances for each of our patients is core to what we do in general practice. We have such a privilege to be able to see people over time. And for our patients that are in this situation where we're looking at starting change, being able to support them long term. And that is one of the things that many of my patients will say to me as they're cutting down their dose. I just need to know that you're in there for the long haul with me and that it will be okay in the long run. And we'll do this gently and slowly together over time. And that is such an important role that we can play as GPs, seeing people over time, understanding them, creating that strong therapeutic alliance to help them over time.
Thanks, Dr. Wilson. Gabriella?
Yes, so something I didn't mention before was the stigma associated with chronic pain and with taking opioids. And so I think that patients tend to be very sensitized to anything any stigmatizing language or even, you know, size by a doctor. So just when you're treating, when you're prescribing or as a pharmacist, please be just aware of the stigmatization of chronic pain and opioids and how a person might be feeling if they're taking opioids. And even though, you know, the best option is to transition them to a lower dose or off them completely, just to be sensitive to the stigma they're probably feeling and the anxiety they're probably feeling. And I think that you'll have much more success with them if you're very sensitive, you know, to this stigma and to their anxiety.
Thanks, Gabriella. So we'll leave it there. There's information on the screen here with our website information. It's easiest if you just type SafeScript New South Wales into Google, though. That'll be the first hit. Feel free to drop us an email if you've got any questions coming out of this evening. And that's really it for that. I'd like to really thank our panel members, Dr. Wilson, Dr. Datta, and Gabriella, for sharing their time with us this evening and their experience. And thank you all for joining this evening. Please don't forget to organise your CPD points from this evening. Michael, you've got some information about evaluation.
Yes, I do. I'll just share my screen. Yes. Okay. Yes. So thank you, Andrew, for our speaker for this evening, and of course our panelists. That was a wonderful session. So we're wrapping it up. So if everyone could please take a minute or two just to complete the event evaluation, either by scanning the QR code that you see on the screen now, or using the link that was sent on the chat box earlier. So if you click on the chat box on your control panel, you'll be able to see it, scroll up and you'll be able to see it there. Following the session, your browser will also open to that same link for the online evaluation. So if you can please complete that, that would be greatly appreciated. For those who have to shoot off, we'll also send an email with this link tomorrow and a statement of attendance, and a copy of the slides will also be sent out in the coming weeks. So I'd like to thank everyone for attending, and have a good evening. Thank you so much.
Thanks, Michael.